Hello, my name is Anthony Lyman. I'm honored to serve the state of Iowa in the capacity of Chief Information and Technology Officer for the Department of Human Services. If you watch the introduction video by Director Matney, you are aware of our Medicaid Modernization Initiative, starting with provider enrollment and management outcomes. I'm focused on ensuring our modernization efforts are taking advantage of modern technology, which is advancing at an ever-increasing pace. We have a risk of making improvements that attempt to produce a newer version of our current state. Liz and I are highly aligned on achieving a loftier goal with modernization, which perhaps may not look anything like our current worldview or experience. I'm excited to embrace this challenge and take this opportunity through modernization to dramatically improve our ability to serve Iowa citizens. Our modernization team has been assessing our systems environment to understand the current state and determine the best approach for modernizing. First, let me provide a bit of background on our current state environment. Many of the systems we use today were built in the 80s and 90s, and many are operating on mainframe technology. A good amount of Medicaid processing still runs on our core MMIS system, which was initially developed to manage Medicaid member and provider information, process prior authorizations and claims, manage third-party liability, and support reporting and other administrative functions. We've continued to add and integrate systems over time as new laws and policies are enacted, including the creation of multiple sources of eligibility data, a system to manage premium payments, a system to handle waiver and long-term care case management, and an informational portal for providers, an eligibility portal for members, multiple systems for managing workflow and documents. We also have commercial off-the-shelf products implemented to manage program integrity in pharmacy, point of sale, drug rebate. We have over 20 systems we maintain as part of our Medicaid enterprise system architecture, operating on a wide variety of underlying technologies. Each operational system is programmed separately with our business rules and stores data independently from other systems, creating opportunities for business rule and data discrepancies in our environment. To keep all of these systems coordinated, we maintain hundreds of data exchange interfaces and also created a data warehouse where we consolidate data extracts from each of the operational systems. Unfortunately, it does not currently support data quality management, reference data management, or master data management functions. As you might imagine, the resulting environment becomes more and more challenging as changes continue to be layered on top of old technology. Our ability to respond effectively to business changes continues to degrade. New laws and changes in policy are often addressed by the addition of new systems, data sources, siloed rules processing, and data exchange interfaces. In 2016, we made the transition to managed care. The previous picture we just discussed comprised the full extent of our Medicaid enterprise systems. We also have other DHS enterprise systems integrated with this environment, as well as external systems. Adding the MCOs created additional data exchanges for member eligibility, provider enrollment, and encounter data. We later split out dental coverage to be handled by prepaid ambulatory health plan payers. Okay, so the big question is, how do we go about modernizing something like this? We've been working with CMS on certification approaches and put together our thoughts on an implementation approach. Please review the remaining informational videos for more information on our planned approach.